All right, it's Thursday night. Here we are live from Chelsea, Michigan, the beautiful. Also, it's April and it snowed today. So it's pretty exciting for everybody in the clinic. Big thanks to those of you that came from out of town and are maybe not as used to the snow as you might hope. So here we are. Let's rock and roll. 6 o'clock, time to jam. I have a fun conversation today. I think those of you that are in the autonomic world will very much enjoy it. Glad to have you here. I'm just going to kind of take a minute and let people come on into the room. Hopefully we see our normal cast of characters, which is great. We've got Jinya on. What's up, Jinya? Should we pop you on the camera real quick? Just kidding. I won't do that yet. Okay, so we're going to roll. So for those of you that are interested in POTS, autonomic disorders, we tend to talk about that a good bit here. That's what people are very interested in. I want to talk about it today. It's going to be fun. Hopefully you guys also will have some questions about it as well. If you follow some of the things that we post and share in our social media world, when we follow those things along, hello, Farzak. Good to see you, my friend. Glad we're here, ready to rock. We're going to talk about POTS. So the reason we're going to talk about it is I post things on social media from time to time where I'm trying to drive home this idea where we stop really putting all of our focus on heart rate as the main driver for our clinical experience, right? And I know that seems strange because it's like, well, it's diagnosed based on heart rate. So what I thought, maybe we go back to the beginning and we start talking about where does this diagnosis come from? Why do we use it? Like, what's the history? And I think it's useful because if we explore the history of this thing, then I think it will give us a better indication of like how we're using it, what we should know, how we can be more empowered going forward. Cool. So that's what we're going to do. Megan Bradford, hello. Great to see you. I'm going to try to pull up this little thing I put together for you guys. Let me get this going here. And Ginny says, we've got a question from Sarah. Sarah, I will help you out with that. We're going to cover, we're going to have this part of the conversation. So stick around. We'll get to that here in just a little bit. So we're going to share this window. There I am in the corner. Let's see what we got here. Let's see if I can shorten. Whoa. He really wants to fit it. Okay. Let's do it like this then. Okay. Hopefully you guys can read it. I've tried to make it big enough. So this is going to be based on a couple different papers, but the main one, it's a 2022 paper written by Olshansky as the lead author. It's called Postural Orthostatic Tachycardia Syndrome, a Critical Assessment. And I think it is a well-timed paper. It's great. It's 3 years old now, but it still definitely fits our purpose. So we're going to call this one, though, Postural Orthostatic Tachycardia Syndrome, a Concise Critique. And here's why. So here's where we're at. What is it? Typically, we think of POTS as excessive heart rate rise. When you stand up, usually orthostatic intolerance is involved, right? But the problem has become is the water has been muddied. So we kind of now have what is more of a vague syndrome, and we need to move it to something that's a little more clear. So we're going to kind of track the origin story. I'm going to move forward. So first time somebody described it was Rosen and Cryer. They were in 1982. They noticed that they could have tachycardia that wasn't like persistent. You could change it by standing them up and then laying them down. It would change their level of tachycardia. Really good insight, really useful stuff. Then Lowe's group out of Mayo decided, hey, we're going to do a study. And so they looked at a number of people, and basically it ends up being a study kind of on about 16 cases, right? Largely. and they compared it against some controls, and a couple things became a little bit of a problem. So what they were looking for is they were using a heart rate increase that was bigger than 2 standard deviations above the controls. So this is or above 110 beats per minute baseline, rising more than 20 beats per minute on the tilt without a blood pressure drop. So that was the original criteria. The problem was when you actually go back and look at it, number one, really small sample size. Okay, we had 16, basically 16 patients. Number two, and I'm going to move this so I'm not looking over to the side. Let's do it like that. Whoa, full screener. Okay, so number two, here we go. Sorry about that. This will be easier for me to kind of follow along with you. Three of the people that we said there shouldn't be any major blood pressure drops had hypotension. So they had drop in blood pressure. Two of them didn't have heart rate rise more than 100 beats per minute. So then we kind of get in this range where based on all of this, we don't have like a clear cut criteria, and it kind of makes it unclear going forward, right? So that's 1993. This is a while ago, but we kind of like start to use this terminology of POTS. It's kind of meant to signify like we have this elevation in heart rate that seems to be amenable to orthostasis or standing up. We've given it this name, right? So fast forward to 2009, and then we kind of like start bolting other things onto it. So we're going to add hypovolemia, which is interesting because hypovolemia is kind of like its own thing. So hypovolemia means like we have low total blood volume, right? So it's kind of like its own idea to start with, but it kind of gets bolted onto POTS. And then in 2015, we kind of do this heart rate standard where we're just saying greater than 30 beats per minute change in adults, greater than 40 beats per minute in youth, which is cool. But then they also said like, but we don't need to do a tilt, and maybe we don't even need to have heart rate criteria. We'll just do it based on like kind of like this group of like all autonomic symptoms. But the thing that's true is you can have POTS and also have other autonomic symptoms. But it goes the other way too, where you can have other autonomic problems that aren't necessarily POTS. So we get in this thing where we kind of like start lumping all this stuff together, and we get this big like, you know, casserole of things that are tacked together. So we went from this thing that was meant to signify like, hey, we noticed these heart rate levels go up when we're standing, they drop back down when we're laying down, and they get symptoms from that, to starting to include autoimmune conditions as a part of it, diagnosing based on fatigue, diagnosing based on brain fog. And there are all these things that like anybody that's been around the block understands that these are things that like have an overlap with tachycardia, orthostatic tachycardia. But also they have overlaps with lots of other things too. So they become what are called non-specific descriptors or non-specific symptoms. And because of that, it makes it very hard to say, oh, you have brain fog, therefore you have this thing. Because you can have a brain fog and have lots of different things, right? So, so we're basically taking the teeth out of the term in a long ways. So downsides to this, number one, it confuses the diagnosis because it makes it so it's like you can say it one word, but now it means lots of different things. It becomes like a slang word. Number two, it harms care. And that's really, really like the most important thing to me, because it means that we kind of are lumping people into this one treatment bucket, creating a lot of assumptions without actually digging in and seeing what's going on. So we miss this opportunity to really reach out and help people. Okay. So, so that's kind of the basics of it. So anyway, and then the third part that was brought up by this group is that it can be driven by self-diagnosis. And I kind of sit on both sides of the fence of this. So number one, like in a physician's office, generally people don't want like people perusing the internet and being like, I think I have this. But the reality is like there are a lot of tools now that make that way more available than it used to be. But it doesn't mean that we synthesize it correctly. And now we can end up in a situation though where people start directing their own care, and we can get problems with that. Jeannie, are we doing a Barrow Institute commercial in the chat over here? What's going on? Barrow's amazing. Takes insurance. That's fantastic. Sounds like that's interesting. They might maybe on staff now. Okay, so saying if one has all the criteria, it's a syndrome, i.e. POTS. Yeah, that's not really what we mean by that. So POTS being a syndrome, when we name things as a syndrome, it's a collection of symptoms. Yes, but what the point, I think, what maybe would be really useful to understand is naming a syndrome isn't like the most useful way to then seek out care. It's just like it's a shorthand way of describing a thing that you notice. You know what I mean? So because something is a syndrome does not necessarily mean that that is the way that we should create criteria for serving someone. So I think that part's a really important part. So moving forward from that kind of takes us into this next part, where when we start to name things based on their symptoms, this is a very weak way. This is a very weak way to be able to understand what these symptoms are. We're going to start. Okay. There we go. Okay, so sorry about that. So symptoms-based means like, it doesn't really tell us what's wrong. It's like saying like, hey, you come in with headache, and we call it cephalgia, which just means like fancy word for headache, right? That doesn't help you to get to understanding where the headache comes from. So being able to name something based on the symptoms or a collection thereof doesn't really tell us precisely what's going on. And that there's probably a period of time where calling something by like what it looks like makes a lot of sense, especially from a records keeping perspective. And honestly, like for a very long time, there were a lot of mechanisms that we just don't have availability to understand. So it does make sense to name them that way. However, as we progress through time, that isn't necessarily the most useful way to do it. So where we're at is, how can we do it better? And that's really kind of what we're focusing on here, is like, how do we make even more improvements to this? It's also what the Olshansky paper here is talking about as well. Like, how can we do a better job? So here's the problems with it. We end up with this like wide swath of symptoms, right? And you guys know that like a lot of people feel these things: lightheadedness, fatigue, palpitations, brain fog, on and on, digestive problems. Here, let me show you another list real quick. I'll pull it up. Let's go with here. Give me a second. So like these are just like some of the things that commonly are mimics of POTS, mimics of autonomic problems. But let me try to make it bigger for you. But may not like tell the whole story. If you're watching on a phone, super apologize. It's gonna be hard to read. Hopefully, if you're on a desktop, maybe you're throwing this on your giant 80-inch screen in your theater room, whatever it is. But hopefully, you can read these. But there are tons of things that people experience, symptom-wise and otherwise, that kind of have overlap, and you could see where these things may be related. And I'll let you kind of look at this and read them, but they can go across different conceptual groups, where you've got autoimmune related conditions, you've got arthritic types of conditions that can overlap with the autoimmune ones. You got GI problems, so you got gastroparesis, slow motility, but then you can also see like SIBO and IBS and MALS, which we don't have to get into, but these are all like different things that can be associated or have crossover with this primary concept of orthostatic tachycardia. Okay. So I think it's really useful actually to kind of talk about that a little bit because it makes it a little easier to understand. What we want to move toward is more of this idea of being able. So this isn't the only condition this is a thing with, right? So I come from the world of talking about things like concussion, right? Where we see these overlaps. Like you can do something simple like, hey, let's compare concussion-based symptoms to whiplash-based symptoms, right? And you realize like, whoa, those match quite a bit. So then you have these criteria where like, well, we have to then be able to say, how do we specifically diagnose what are concussion and what are whiplash? So that's where these things start to get muddy. So you have to have what they call inclusionary criteria, which means the diagnosis has to be based on a positive finding rather than an accumulation of negative findings. I think that's what Jeannie was talking about. Another example of that would be something like functional neurological disorder, which we should probably talk about on its own separately because it's very important. But basically, functional neurological disorder, actually, when they came up with that nomenclature, which wasn't that long ago, it was a really great move because they said like, we're coming out of this world of I think malingering, which is like the medical world for you're faking it, and that kind of morphed into like a psychogenic movement disorder, which means like it comes from your mind, which is fine. But then they were like, well, but there's like this other thing that's going on where these people have a real problem, but it just doesn't match like a hard brain lesion. And the way to think about that is like, if your car's not working, you take a picture of a car on the side of the road. You take a picture of that car and you send it to the mechanic and you're like, why is this car not working? The mechanic will be like, I have no idea. I can't tell from a picture, right? But you may take the same picture of a picture of a different car that has smashed into another car, and you could take a picture of that one. You could send to the mechanic, and they would be like, "Well, that is in a car accident, so like it's totaled." So you can think about that the same way when we use imaging technology, looking especially at things like the brain, because by looking at the brain, you can see if structurally something's going on. But it's hard to know functionally what's going on from a picture, just like if you took a picture of a car with an engine problem, right? So anyway, so this is kind of a longer subject to say like FND or functional neurological disorder is an example of the same thing, where there's something that's going on, it's real, but it's not easily detectable based on current neuroimaging standard. Okay, so that needs a name. Cool. We call it functional neurological disorder. Great. It has its own inclusionary criteria without getting into it, but you can, you think about things like distractibility, rhythmicity, all these things that become positive criteria. Okay, so you can apply that same thing when you're looking at like POTS. When you start to add in, when you start to create a network of, these are just a collection of symptoms or a syndrome, as we talked about, there's nothing that you're measuring or you're detecting that says that those things are all related or they're not related to something else. So you have to have something to anchor to that allows you to be able to measure what is going on. And that's really where we're jumping in. So from this perspective, so Marilyn, welcome as well. We just blocked Jeannie. We didn't block her from participating, but I can't see what everybody else is saying if we're just talking about Barrow. We mentioned Barrow's great, fantastic. If you want to go look it up, go for it. But that's not what we're here to do on this stream. If you don't like that, you don't have to be here. And to say that I'm going to go ahead and put this up for everybody, because it's not welcome here. Wow, did you just block that girl? Shouldn't you be in the business of helping others no matter what? That makes you seem like you're about the money, doctor. No, it makes it seem like I'm trying to talk and you're doing an infomercial in the chat room, which is not useful. Okay, so talking about a clinic that I don't even know what the clinic is. while we're trying to have a conversation about POTS that we're now interrupting isn't really that useful. You commenting, sure, virtues are great. I'm super happy for you. I'm glad she can help. She's there, but we're also trying to have a conversation that's about a specific thing. So let's take it out. I'm happy to see if you guys want to chat, if you want to ask questions, fantastic. But also, like, please be respectful. I'm doing this for free. There's people that come here every week. They try to learn. That's what we're trying to do here. We're not going to do this. Okay. If this is what you're going to do, then you won't be invited back. Thank you. Okay. Okay. So moving forward. Sorry about that. Sorry about that. This is like a common theme now in the old YouTube. It's interesting. So when we look at these types of disorders, we want to be able to anchor it to a real thing. And most of you have felt this because sometimes you feel like you go to the doctor, we're trying to find what's going on here, and you just kind of feel crazy. You're told like, hey, it's anxiety. It's going to be cool. Or sometimes it is, but not for everybody. Okay. Okay. So as we move forward on that, this is a little thing out of that paper. So the latter expansion of this syndrome's causation inevitably broadened the range of associated conditions considered POTS-like, as we're talking about, including volume depletion, inflammatory disorders, autoimmune diseases. Consequently, the original unified and meaningful initial POTS description, which is a select group of patients with orthostatic intolerance and sinus tachycardia, has evolved to encompass a multitude of patients with a constellation of complaints. And I think the authors here, I know I don't love reading to you guys, but I think they did a really good job of like stating what the problem is here. In many instances, the presenting symptoms are non-specific in nature, which encompass multiple body systems and are often not even associated with orthostatic intolerance. There may not be an identifiable autonomic disorder at all. So it's a lot of talking here, right? But what it basically means to say is that we have to do a better job of like narrowing this down. And you've heard me beat this drum before, and I guess that's what I'm doing right now. But as we're looking into this, we say, okay, maybe we don't name it based on symptoms because it's not that useful because you have a lot of different symptoms, right? You guys have felt that. So people that have, Lyme disease can have symptoms like this. People that have a short-term infection can have symptoms like this. People that have thyroid disease, SLE, different autoimmune, like you can have these overlapping types of symptoms. So it's not that useful of a way to think about it. What I think is more powerful is if we actually shift and we start thinking about it in terms of the underlying physiology, meaning what is going on in the body that actually is causing these problems to persist in the first place. With POTS, this type of dysautonomia, we can see that it becomes chronic. That's one of the kind of characteristics of it, is it just doesn't go away. So if that's true, there's a physiology underneath that that is impairing what is going on. Okay. So how do we start to pull at that? How do we start to identify it and move forward? Heart rate started off as this wonderful way to look at it because in 1982, that's what we had. That's the thing that was originally noticed. Like, hey, this is going on. We should figure out what is happening here. Okay. But the deal was, for many cases, the heart rate component actually becomes the signal. It becomes the trailing indicator of something being wrong. In many ways, it is the thing that is saving you because it's the way that your body can compensate for an error to try to maintain your ability to keep your consciousness, keep your capacity when you move from that laying down to standing up position. Okay. So there you go. So that's kind of what we're talking about here. Let me see if I missed anything. So standing shifts blood volume downwards typically, right? That's part of just the normal response of standing. If you've got an awesome brain and an intact neurological system, you can compensate for that. No big deal. Everything tightens up, pushes the blood up to your head, all good. The system that's in charge of that, we tend to just loosely call the neurocardiovascular system because it's neurology. So it's your brain and nerves. Cardio, heart, vascular, blood vessels, that whole system and how it works together. Encompasses the autonomic nerves, the autonomic neurons in the brain and brainstem, their ability to control vascular tone, and the sensation of that through different barrel reflexes. So if we fail to adjust to these things, then we start to see compensations. One of the common ones is we just get drops in cerebral perfusion. And if cerebral perfusion drops, or that's blood flow in your brain, we have to compensate for that. Otherwise, people go down. Okay. So a couple examples of that would be problems with vasoconstriction. So that could be a control mechanism, right? My brain doesn't control it coming down. But it could also be I've got some sort of problem with the nerves, a neuropathy that prevents my brain from being able to generate the signal going down to control the vessels. Or the feedback loop of being able to detect the pressure not working can cause that same feedback loop, right? So in this neurocardiovascular system, you can look at the nodes and try to understand how they're working together. We can also see, like it says here, volume issues. So if we have problems with venous return or cardiac output, that can cause tachycardia. Again, it's the same thing though. Is it a problem in the heart? No. If it's a problem in the heart, then that becomes its own problem, right? But if it's a problem in the control systems that would allow us to normally circulate the blood, now that's where we start to talk about problems. Barrel reflex fault, okay? That's another example of how we lead through that. The ability to detect pressure is the primary way that we can do something about it. So another way to think about that would be looking at a thermostat, or having a thermostat that works is the easiest way to maintain a constant temperature in a room, right? If the thermostat doesn't work, the ability to then turn the heating and cooling systems on appropriately is going to be impaired. They're going to be too slow. They might overshoot, they might undershoot, whatever may come. Okay. So hopefully that helps. All right. So what we want to shift toward is let's think about things like this, like perfusion failure, for example, not necessarily heart rate. Okay. Heart rate can be an awesome tool to be able to evaluate that there is something wrong. I love that part, but it doesn't precisely tell us what is going on. Cool. So benefits, we want to be a little bit more precise, testing things that we talk about. Testing things like perfusion, that doesn't necessarily have to just mean in the brain. It can mean how are we circulating blood effectively. A lot of people that have problems with circulation also notice they have things like Raynaud's, where they get color changes in their hands or in their feet. We notice that it looks like super, your legs get super purple if you sit up or you stand up, or you might get reticulated patterns in your legs where it looks like spider webs. So we also may see like different amounts of like pooling in the abdomen or swelling or changes in kidney function, where we're changing the way, like the frequency with which you're going to the bathroom, the way you're storing electrolytes, all these kinds of things as well. Anemias are a big part of this. So we can kind of look through and understand the core feature is like, can we use the blood as a mechanism to be able to get fuel everywhere in the body at the time it needs it? And then that allows us to be able to really get to the ability to not just try to support the symptom, but can we support the underlying physiology? That's super cool. And if you can support the underlying physiology, now we're in a position where you're just becoming stronger. So the same way, if you weren't strong enough to walk up the stairs because you were weak, allowing your muscles to get strong enough to where they can take on that challenge now applies to several other things. Like now I can run, maybe I can walk up a hill, maybe I can do, I can pick up a rock, whatever. I can do all of these things because I can do that. And I think that that's the part that's really important that I keep harping on, is the idea of being able to solve the underlying physiology is such a strong driver to see people that are typically very young in these conditions be able to have an opportunity to work toward a more full life, rather than being limited by these systems. There's just not a way to chemically override them in a way where you can just like walk away from it. So there's always a give and take. So anyway, that's kind of the basis of that. Is we want to think about it in terms of taking it out of these diffuse categories of symptoms. It's very useful to be able to describe it, to be able to walk people through what you're feeling as a patient. But then on our end, as a physician, we have to be able to take that information and then return more questions to be able to dig into how these things are related, so that we can then turn around and find the right measurements to understand how these things may be working together and where the linchpin is to be able to say, well, if we can improve the function in this area, would that have a net benefit for this person? So that is my little history and sales pitch for trying to find the root cause. Sorry for the interruption there in the middle, but I hope that it came through okay. So the questions that we have, I'll take them. Thanks for working through it with me. All right, so thank you very much for being here. We've got, oh yes, Peace Love Mung Bean. Good to have you back. Oh yeah, sorry. Peace Love Mung Bean, I'm going to answer your question, then I'm going to go back to Sarah's question. So her Peace Love Mung Bean are all, let me move this back over here, are all POTS symptoms. Oh, sliding screens around here. Either caused by a response by or a response to reduce cerebral blood flow to the brain while upright, regardless of the underlying cause. This is a really good question. I would say one of the things that tends to happen with increased heart rate is that it's trying to make up for the fact that we aren't going to be able to effectively circulate blood through the system. We're looking at the difference in cases that are between, there's this key function that we kind of skip over sometimes, and that is we're specifically looking at someone that's lying down that does pretty normal, right? You guys, if you've been there, you know that if I'm laying down, life's pretty good. My heartbeat's normal. I feel like I can think pretty decently. Like my life is significantly better laying down. Like objectively, we can measure things. Things are pretty normal when you're laying down. But when you are tilted up, we've changed the game. So if we've changed the game now, we're saying, uh-oh, like I'm getting these symptoms that are around, I'm having to rev up this system because I'm not able to properly energize it. And a lot of the symptoms that we experience are around that ability to try to upgrade our energy level. Okay, energy doesn't mean like you're, I feel great. It means like the mobilization of oxygen and glucose. So we have these symptoms that are more perfusion related, right? I feel brain fog, eyes are blurry, got some ringing in my ears, I feel nauseous, like these kinds of symptoms. But that you can also see like I'm sweaty, right? My mouth is dry. I got that like sticky saliva. My heart rate's up. I feel like my vibrating on the inside. Like I feel anxious. I feel like wired up, right? That's a common symptom as well, but also one that you would expect to have if you were having a hard time like distributing blood through the system. Or another way to say that is like if I'm having a hard time distributing blood, the number one place it's going to show up, the hardest place to get blood to, is my head, because it's at the top when I'm standing up. So I have to push blood against gravity to make that happen. So where am I most likely to notice a symptom? It's going to be related to my brain. And so we see the two sides of that. Number one is like, boom, things are bogging down. But then number two is the ramp up of this metabolic system to be able to try to push energy somewhere. I may spike my glucose. I may spike catecholamines, things that create more alertness to try to be able to maintain that integrity. So I think like writ large in a pragmatic way, The elevation of heart rate is largely due to the fact that we're not able to perfuse very well, number one. But then number two would then be, well, why? What's causing that? And then how do we move forward with that? So is the problem in the brain itself, where we're having an autoregulation problem or a hypocapnia problem? Or is it in the ability to actually push the blood up, where the system isn't strong enough to maintain it? Or the sensors that would detect a lower flow aren't picking it up and aren't engaging in that in a way where it's causing the distribution to happen. So let me know if I answered that okay. I'm happy to keep going through it because I think that's such a big question, such a great question. Love it. I'm going to go back and ask Sarah's question. I can't pull it up because it's in a different part of the chat, but it says, is there anything that can help or prevent passing out or near passing out? So syncope or pre-syncope. She knows sweaty, shivers, throwing up, lightheadedness when having a bowel movement. And then she said from there, dysautonomia is a part of this, basically Valsalva. I think that's a really good question, and it's one that I actually hear quite a bit. And it can be related, number one, to that Valsalva. A Valsalva is kind of like the pressure that you put in your abdomen, like when you're going to the bathroom, or you think about like blowing up an air balloon or something like that, where you're creating that pressure. When you create pressure, a couple things to keep in mind. As I fill up my chest and I tighten those muscles, it's creating a pressure where I am, number one, making it harder for my heart to push into the artery, right? Because my heart is now like pushing against resistance. I'm like pushing against my heart. I'm pushing down around the arterial walls. So I have to have even more integrity of that pump to be able to push through there. The only way I can know to be able to shift that context, shift the physiology, as we said, to be able to overcome that with your heart is to know that it happened in the first place. So we have to have pressure receptors that can detect it quickly, transmit that to the brain, and have the brain change gears and say, we're bearing down right now. We got to go into bearing down mode, which is going to change the way that my heart beats, the way that my blood vessels work. The other part of that, though, is you've all seen this. Like if I bear down long enough or hard enough, I'll start to get veins sticking out of my head, right? And what can happen is two things. Number one, that pressure makes it harder than for the blood to drain passively out of my head through the veins, but it also makes it harder to push blood into my head. So a lot of people will notice that they do feel, whoa, dizzy, lightheaded, like they're going to pass out. We have a test that's specific to this. It's called a Valsalva test, where we have people blow in a tube and we measure the blood flow into the brain versus what's happening in the heart, so we can see what that relationship is. That's the baseline of what's happening. Now, what can you do about it? Okay. So as far as tricks that you can do, I don't know for sure. I don't know for sure what the reason is that you're having them. So that's number one. So I can't give you like, the script or the medical advice that would say, but the things that you could start to consider are, well, number one, do I have other baroreceptor type problems that I notice? So the easy one that we've been talking about all day is like when I stand up, do I also notice that I feel off or funny, right? Number two might be, do I have a measure of tachycardia that is there not just when I'm standing up, but it's all the time? Is there a problem that's specific to my abdomen or to my bowel system where I'm actually stimulating the bowel itself makes you feel like you're going to pass out? Because that can be a thing as well. Also, if we have decreases in vagal activities, those can also lead to it. So there are a lot of different things. As far as like quick things that people often do to be able to mitigate this would be, number one, is trying to not strain. So using things that help, create softness in the stool, be able to be in a position with your body so that you're not having to strain, can be kind of the number one way. From there, your differential would be like, does it only happen when I strain, or is it a bowel movement in general, or is it the position I'm in? And then you can start to differentiate from there, kind of what's going on. We see these cases a lot, not just with, well, let's talk about it just with bowel movements, but where people will be on the toilet and then boom, and then they pass out, which is dangerous because there's a lot of hard stuff in a bathroom that you also don't want to hit your head on. So I think it's a really good question. I want to be more specific in my answer, but I also don't want to lead anybody wrong, and walk the line of giving anybody advice that maybe would be overinterpreted. So great question. Thank you for asking, Sarah. Okay. Practitioner, clever. I like that. Having trouble compensating these days without propanolol. Sure. So propanolol, for those of you that are in the know, propanolol is a beta blocker. And beta blockers have kind of two effects. The biggest one is that they will reduce the heart rate. So the ability to be able to generate that faster heart rate, it just slows it down right at the adrenergic channel. So it blocks the beta adrenergic receptor. So right at the level of the muscle. And that can also have some effects in the blood vessels as well. That can help to kind of help to compensate for this a little bit. And I think that's pretty good language from practitioner. Thank you. That propanolol can be a really nice tool for helping to be able to compensate from like a cardiac level. So you're kind of intervening at the heart and saying, we're just going to slow the heart down. And if we do that, it'll allow the heart to at least catch more blood that's coming in. It doesn't really address why the blood isn't getting there in the first place or why the tachycardia is occurring, but it can be a relief, which can be pretty useful. It has upper limits, so it's harder to exercise when you're on propanolol for a lot of people. And for some people, it doesn't work because it doesn't work for that particular mechanism. But a lot of people do find that it can be a compensation tool that can help them kind of like push through and keep on going with their life. And sometimes the hope is that if you can do that, maybe it'll get strong enough to where you can start to reduce dose just by getting stronger by doing more things. It's kind of like kitchen sink model. Like I'm just going to try to keep doing my life, and hopefully that sticks enough to where my body kind of compensates for it. So I can feel your pain on that, but hopefully you're able to do as much as you can and keep going. Okay. Cool. Thanks for messaging. I appreciate that. All right. Next up. Oh, actually, hold on. Before we do that, I'll come back to you. Promise, Ashley. But just to finish following up with practitioners, so that's it. Not physically active anymore is decompensating, and that's kind of what you're trying to prevent by using those medications. But also, if we can get underneath it and get to the underlying physiology, that's a beautiful thing because then you're not compensating at all. You're just like getting stronger, which is that to me is like that's the thing. That's the thing that we do this for. So thanks for writing that in. Okay, back to Ashley. Can it be normal with POTS that when you're sleeping, you get tachycardia? The only way I know this has happened is waking up with active minutes on my Fitbit because my heart rate was being so high while sleeping, for example. So this can happen. It reminds me of a case that we just had. I can't remember if it was last week or the week before, but one of the things that we were talking about in that case is kind of a similar thing, waking up tachycardia, kind of like short of breath, and like a little anxious, a little panicky, But then when we do the measurements, we notice that the same position that she was sleeping in, if we re-engineer that position with the Doppler ultrasound on, we see that the cerebral perfusion pressure is dropping. So when we look at that, we say, no, well, number one, like that position is probably not great for you. And number two, it helps us understand a little bit about like how just that positioning can be so profound in two ways, like the structures that travel external to the spinal column, things that are coming kind of through this carotid sheath, but also the things that are traveling through the spinal column and the spinal cord, right? So they can both be affected by these positional bases. So that reminds me of that. And then, but by being able to kind of recapitulate what's going on with the way she moves and then not putting her in a restricted position at night, then we see those minimize. So that kind of goes away. That's one case. That's not this case. I don't mean to oversimplify that, but that's like an example to learn from. The other thing to think about would be like the relationship of oxygen, apnea, things that are going to like upset your apple cart in a way where your body is trying to say like, yo, we got to move. Same as you kind of wake up in the middle of the night and your arm's asleep and it's like, oh shoot, like I got to roll over. You can think about that in a similar vein for a lot of things that occur in this world that are happening overnight or lasting into the morning, where it's waking you up and saying like, yo, we got to do something about this. Something's not right. And then you're kind of working backwards to see, well, what could be going wrong? If it's specific to just tachycardia, is it something where your heart is under a different load? Is it where we're getting a surge of something related to your blood sugar or your thyroid or, any of these number of things? So I don't want to oversimplify it, but I do think examining what is going on while you're sleeping and actually working back from there has been super fruitful in our approach. And I hope that maybe thinking about that a little bit, you might be able to notice some things, and then we can start kind of working our way back from there. Would be awesome. So hope that helps. Who do we have here? Daniel Schiffer. Hoping to meet you in person soon. Seriously consider coming over from Toronto. Claire has been very helpful over the phone or email. Only 5 hours away. Love to have you. Hope I get to see you soon. Let me know when you're coming. Send me a note so we can have, flowers and balloons and a band all standing by waiting for you. Awesome. Thanks for being here. Take care. Okay. Ooh, we got a lot. I'm just going to keep going down here. I might have missed like some of the conversational stuff because I'm just going one by one. So I'll try to kind of come back to them as we're going. But I'm having fun. Thanks for being here. This is really great. I'm glad that we're asking. Number one, these are great questions. These are the same ones that I get asked every day in the clinic. And they're the right ones to be asking because they make the biggest difference on being able to like work your way forward. It's not as easy sometimes as just getting like, boom, ChatGPT, there's my answer, and then here's the outcome. Like the reason I think for a lot of people that this is frustrating is because number one, it's hard to get to diagnosis. That part sucks. I hate that. But then also you're kind of at this, this crossroads of being able to decide, like, to what degree do I just want to be done with the symptoms? Like that's a legitimate thing. And then like, can I just take something that'll reduce this now? Because I'm suffering. Totally understand that. And then at the same time, you're going, all right, well, once I get to that point where I'm like, not just fully dead suffering anymore, I kind of want to just like get better. And then you're in the like, I got to work part of the system. That's kind of where we fit in. But man, the reward on that is so dang high because you're actually literally physically stronger again and able to tolerate your world again. Okay. Ashley had a little follow-up. She said, can it be normal with POTS when you're, oh, no. No, sorry, wrong one. That's one I just did. Oh, she said she does have sleep apnea as well. Yeah, so this is kind of where, not taking the quick answer and like actually doing the hunt, figuring out what is behind it and how these things are related, probably has a lot of upside to it. So I hope that just spurs a curiosity and can help out. Okay, so let's go back up. Let's see here. I think we were on air hunger. Here we go. So Ann James, hi Ann. Ann James asks, is air hunger a symptom of POTS? Well, air hunger is a symptom that can kind of cross a few different diagnoses. And it's also, want to classify what air hunger is. Sometimes it can be like, I can't catch my breath to some people. That's how they might describe it. Some people might describe it as like, when I take a deep breath, it doesn't feel like it goes in all the way. Like that kind of a breath. Don't like the way it feels. But yeah, taking that kind of a breath where you're like, can't get it all the way in can be another way. And they can come from different things. Sometimes it can be related to changes in oxygen CO2 relationships. Sometimes it can be from changes in brainstem activities. Classic ones are compression-based syndromes, sometimes cerebellar ectopia. So, sorry, I was reading another one. So the short answer, it can be part of that sequela, especially when breathing is kind of at the core of what's going on for people. So for some people, the tachycardia can be from hypocapnia, where their breathing rate is off, like their brain's breathing mechanism isn't working right, and so the rhythm gets off, or the concentration of blood gases gets off, and then that can cause that kind of weird breathing. The one we talked about today, you know who you are, is thinking about, like, you breathe in and you breathe out, but it's like you continue to keep breathing out because the relationship hasn't kicked in to like normalize. Okay, let's start breathing again. So you end up like holding your breath on the out is a common feature as well. So it can be a symptom. It can be a symptom of some sort of autonomic problem writ large. Second question is, do you want to think about it as being a central autonomic problem or a peripheral autonomic problem, or is it a problem within the actual clearinghouse of the lung? Maybe there's something where there's an inflammatory problem, surfactant problem, things like that. So I hope that helps. But yeah, it can definitely fit in the basket of autonomic problems, but there are a couple structural things that you might consider as well, even including like having poor rib kinematics, like the way your ribs move. As a chiropractor, like a lot of times people will call it like I have a rib out, which is as simple as manipulating the ribs so that it expands correctly again, and there's not that mechanical block of the ribs that's creating the problem. It can even be problems with like the lumbar lordosis where your diaphragm can't expand correctly. So like structural, autonomic, inflammatory, those are kind of like some of the hierarchy of things you might consider looking at. Okay. Thank you. Another great question. Thanks, guys. Okay, moving on next. Amanda McClure. Can the stress response from POTS cause gait issues with a person with FND? Great question again. So we'll kind of cover this a little bit, and hopefully I'm keeping everybody involved. But with FND, FND is that functional neurological disorder, like we talked about before. Sometimes there'll be different versions of that. So it might be like a functional movement disorder. But anyway, in that world, can the stress response from POTS cause gait issues? It might not even be just the stress response. It could be a hypoperfusion response. We see that a lot. Another common way that happens is we'll get hypoperfusion, and it may affect like the muscles of the face or the ability to like use your hand, and you might feel like I'm starting to curl up, or my leg doesn't work correctly. You start to see the posturing. And we can see that just by changing those perfusion ratios, we can see it come down. Sometimes it's because the underlying tissue in the brain isn't that strong either. So can the stress response do it? For sure. Stress response makes everything harder with FND. That's kind of part of the characteristics of it. And then working backwards again, like what I'm always talking about. So great question. I would actually love to see what that looks like. Videos are helpful. And then be able to work forward from there. But really good question. One that's really common too. Michael, is it true that if you're young and have POTS in your teens, you can grow out of it? This is what the cardiologist is saying. This is a common refrain from the cardiologist, and there's a possibility that you can grow out of it depending on what is going on, which just means your body is able to adapt to it, which is like the most awesome outcome that you can hope for, because sometimes just by activating the system, it allows your brain to be able to sort through that problem. So can it happen? Absolutely. Do we also find there are a lot of people that are told they will grow out of it that don't grow out of it? Absolutely. So it really, in that instance, it kind of depends on to what degree am I comfortable waiting on it? Would I like to know more about what the underlying is? If I know more about what the underlying is, and we say, like, for example, you're a young lady, you might find that we've got some things going on with hormones, or perhaps there's an anemia, or there's a lingering infection. There may be a probability that like just kind of getting back to a normal life may help push that forward. You might grow out of it. Maybe through that growth capacity, there's a lag in the ability to do that. Maybe so. As those things persist longer and longer, the likelihood that they just go away may go down. But again, I have a bias because for me, it feels very simple to just be like, well, let's just figure out what's going on and see how to solve it. But I recognize that that's not where everybody's at. So, long answer longer is yes, sometimes kids can grow out of it, which is awesome, and then sometimes they don't, in which case intervention may be more likely. So there we go. What do we got here? Thank you very much for that. What are catecholamines? So catecholamines are kind of they're a classification. You probably were actually able to get this on Google faster than you can get it from me. Sorry, but the catecholamines is just a way to describe a group of neurotransmitters. They come from catecholamines, so you're largely going to look at your noradrenaline, noradrenaline, norepinephrine, derivatives of dopamine, these kind of neurotransmitters that are in the system. You can think about them as largely like energy producing. That's maybe too big of a stretch. But they kind of increase some of the activity in the brain that allow you to be able to be more activated, particularly when you think about noradrenaline. Okay. Practitioner, welcome back. You're connecting dots for me. That's why fasting long periods of time are no longer helpful for my ADHD and brain fog. That can be true. Fasting is an interesting beast because it can be wildly useful as long as you have the underlying physiology to be able to tolerate it. I guess I can probably, I just realized I can probably take and fix this. Stop sharing this. Okay, so sorry about that. Yeah, so fasting can be super cool, but for some people, if you don't have some of the underlying capacity to keep the train running at lower energy, people will actually not feel as well, even though you may still get some of the beneficial effects of autophagy and stabilizing blood sugar and those things, which are great. Under stressful conditions, it can be a little bit harder and actually be a lot more draining for people too. So you're just kind of weighing that out and pointing back to that, a lot of things that are generally good when you have a health complaint, they may not be the exact window back, right? So doing squats, generally great thing, right? Makes you stronger, makes you healthy. Squats are great. But also, if you are in acute low back pain, maybe not squats right now. Let's get through the back pain part so that we can then do squats again in the future as an analogy. So yeah, thanks for really great questions again. Thanks for being here. Corey, welcome back, my friend. Good to see you. And then we have Megan. We have a multiple parter. Let's see. Okay, we got 1 part, 2 part, 3 part. 3, do I have a 4? 3, do I have a 4? 3, okay. We'll go back up to part 1. Megan, there we are. Okay. Part 1, why does a POTS flare feel so different than working out, even if my heart rate hits the same number? Ooh, that's a good question. It is also a little bit of specific to you. I know you, you know me, but we're going to say no medical advice over the computer, but some ways to think about it. Deal? Okay, so POTS flare. So I'm going to ask you to define that a little bit. Oh, actually, I think you fixed it here, because I'm going to ask you questions and then you're going to answer them way down here, and then I'm not going to see them. So let me come back up. We'll try to dance this dance. So I think this might be a little helpful. Oh, I see. You wrote it in 3 parts. No, that's not 3 separate things. So when I work out, my heart rate climbs to 120. Doesn't feel bad. It might even feel strong or energized. But when my heart rate suddenly spikes to 120 because of a POTS flare, it feels awful, dizzy, shaky, anxious, weak, totally different. How many plants are too many? Ah, you tricked me. Okay, so back up to part 3. This is awesome question. Awesome question. So let's talk about this. So yeah, taking your heart rate up to 120 under a physiological demand is what it's supposed to be doing, right? Another way to think about that is if I have a sudden POTS flare, it means something happened, and that is my body's compensation to keep me going. If that's, oh, I'm getting, oh, giving myself emojis. Okay, I don't know how I did that. Anyway, so if that's true, we're dealing with like a quick compensation to something that's happening. It's keeping you upright. That's a bonus. We love that. But it's probably not going to feel good because you're going to get all the signals that say like something's up. It just doesn't feel good. The example that we talk about in the clinic a lot of times is like these are all the things like dizzy, shaky, anxious, weak that can come from things that prevent you from getting blood to your brain, whatever reason that is. So it's kind of like if I've got someone that is like, if I have my daughter just like putting me in a rear naked choke and I'm getting where I'm going to pass out, that's how I'll feel too, right? Dizzy, shaky, anxious, like I want, like, get off this, right? Like, don't choke me. So if you've got something that is ultimately downstream affecting cerebral perfusion, it's kind of similar in the sense that it's going to create a tension in your brain that says, let's get out of here. And it's going to activate, it's going to hit that red button that's going to make you feel these things. So it's really normal and it's the right thing. Whereas if I'm exercising, that doesn't signal to my brain is like, this is exactly what should be happening based on this amount of work. Thank you, heart, for doing that. Versus feeling like something's really wrong. Let's get out of this scenario. So really good question. How many plants are too many? We've determined in our household, I think our peak number was supposed to be 53 plants for Dr. Wife Claire Kaiser. I think she has been sneaking new plants in on me. You can see over my shoulder. I feel like those of you that are keeping track, I want to know if this number has grown. I feel like this one right here might be new. Let me know in the chat. Okay. Let's see. Where am I? Eileen. Hello, Eileen. Okay, finding out I had CCI, craniocervical instability, by an upper cervical chiro was such a huge help. Also, PT and dry needling helped, all with dysautonomia. That is fantastic. I'm so happy for you. Yes, absolutely. So in this case, we found a root cause, able to help it. And then we see, lo and behold, that autonomic system is able to normalize. So that autonomic output mitigated. I don't know more about the story. I wish I did, because we could share a little bit more about mechanisms, but I am so happy that that you were able to find some relief with that by hunting down that underlying problem. Wonderful. I hope you're doing great, Eileen. Thank you so much. Trish. Let's see, Trish, have you heard of anyone getting POTS from heavy metal toxicity, like from gadolinium contrast dye? Specifically, that is a tough question. So specific to gadolinium, heavy metals can be a thing that can create problems, but they're widespread. They can be a lot of different things because they can migrate anywhere they want to migrate and settle. So they can lead to like loads of stuff. Ideally, you want them buried away and filtered out. We've got wonderful systems that help us do that. As you know, gadolinium is a lot of times something that we add to the show, usually through medical imaging, and people can have different reactions to that. They're super rare, but I have seen them. So is the POTS from that? Maybe not. Is it something that could be possible? If your body is really struggling with it and trying to reject it, could be. But that's like a big question mark. I don't know. But it would be a thing worth checking out. If you're worried about it, certainly seeking out some help from somebody that has some experience with helping to detox that. And then you can kind of cross off, problems, solve problems as they come, and keep solving forward until you get to the bottom of it. Certainly sounds like maybe you pin down a question that you have, seeking out somebody that has an expertise in that and what to do about it may be worth a consult just to see what's going on. Maybe get a consult and a second opinion. That might be helpful. Again, not medical advice, no doctoring over the internet, but yeah, certainly something worth looking into. Okay. All right, practitioner, welcome back again. I have inappropriate sinus tachycardia, still unraveling and researching. So IST, man, great that you got that far to know that. It means heart rate already starting from an elevated rate. We want to think about, why isn't my brain able to do its normal job to just hold that heart calm and inhibit it? Okay. So if I start from that framework and work backwards, that is usually a very useful frame, as one of my people on here is working through right now, thinking about sensor coming up, hitting the brainstem. Is the receptor being activated? Am I getting the adequate output that's coming down from brainstem down to the heart? Are the nodes in the heart effective? Off and running. Cool. Love it. Keep going. Oh, Eileen's back. Sorry, Eileen. Missed you here. I have chronic fatigue, brain fog from COVID vaccine until I had a seizure, hit my head really hard. Oh, broke my neck. Shoot, still having disequilibrium, vertigo, migraines, tinnitus, brain fog. Okay. Irene, I'm so sorry. So sorry to hear that. Oh, this is Irene, not Eileen. Sorry. I was wondering. Okay. This is Irene. Okay. Thanks for, number one, thanks for just being honest and sharing that. I hope that, I don't know where you are in the world, but hopefully there's somebody near you, or do you have access to someone that can help you work through this? These are stories we hear about every day. I hate it, but being here, seeking stuff out, super great steps. Let's try to get you moving down the road. A lot of good people in here. Let's try to get you going forward. Okay. Okay. Well, let me see. Okay, Irene, it looks like you've asked more questions in here. I'm going to try to hunt you down so we can kind of stay on it. Oh man, you are spreading them out like little Easter eggs for me to find, though. Okay. Okay, so surgery for fusion, C1, C2, C3. That's a lot of fusion. That's a lot of limited motion in that rotation. I hope that's doing okay. Probably going to need to find somebody that can take a look at that and understand how that's affecting some of that proprioception in your neck, and seeing if you're going to be able to modify that. Again, not advice. Oh, and then you're taking a turn on me here. Explain cerebellar ectopia, commonly called a Chiari malformation, where in the 17th week of gestation, so in utero, your brain kind of, you kind of starts out as a line. Your spinal cord and brain start out as a line. Your central nervous system starts out as a little line. It grows a little pouch on top, which is your brain. Eventually that brain grows up, and then it kind of folds over like that while it's in your skull. And then from that position, you kind of maintain your you maintain your brain inside of your skull. So in the 17th week, if that doesn't fold over all the way, you can see where the cerebellar tonsils, the bottom part of the cerebellum, midline part, can start to drift into the spinal canal, or into the foramen magnum, like the hole in your skull, and it can create some pressure. And when it creates the pressure, it can start to impair function. And there's a lot of controversy over how much ectopia or Chiari malformation is clinically meaningful. There's a lot of people that have varying opinions on that, as to whether or not they're causing symptoms or not, they're worth operating on or not, et cetera, et cetera. But definitely worth understanding. Where do you go to start to sort this out? You got to get people that you feel confident in. I don't know where you live, but whether that's somebody local, that can be a great place to start. And then you just kind of start moving up the chain of people that you think may be more and more useful for your particular case. So I hate this for you, but I hope this story has a happy ending. Okay. Okay. I lost my spot. Cindy, are we on Cindy? I think so. Thanks for all the questions, guys. I hope it's useful for everybody. Hope you guys are getting insights for each other. I'll do my best to answer them the best I can in this setting. It's not perfect because they're not perfectly candid answers, because we're on the internet and I don't have all the information, so I'm trying to do them that way, but I'll do my best. Okay. POTS from intestinal malrotation. Another interesting one. POTS specifically could be relative. So if we're looking at kind of the positioning of your intestines, we want to understand, is that creating some sort of torsion in arterial system? And is that torsion in the arterial system creating like some compression that is impairing blood flow, whether it's on the way down or on the way up, like from the heart, either direction. But anything that kind of steals away from your ability to adequately circulate may have detriment on be able to creating venous return back to the heart, which may therefore then accelerate the heart rate. So I think that makes sense. Good question. Lots of great questions. Peace, love, mung bean. Did I answer this one? Might a wearable like that from Lumia Health help patients manage activity to recover from POTS? Great question. Don't know for sure. I talked about this. It might be in a video that's coming out in regards to exercise and POTS, because I think the idea of exercising for everything as much as you can is fantastic. But also for people that have POTS, a lot of the things that lets them know that they have POTS is the fact that they can't, like they're degrading, feeling so bad that they can no longer exercise. I have so many conversations with people that are like, I used to be a triathlete, I was a soccer player, I did everything, and now I can't. So it's not as though it is commonly a function of like people just being lazy. It's a thing that happens and that kind of forces you into less and less capacity, which means you have less and less energy to be able to work. So with that said, the question is then, is exercise like the limiting factor? Is that the thing that's going to save you? In some cases, people do really great. They get stronger and they kind of work themselves out of it. But other people will notice like, this is just like, it makes me feel it's just hard. And maybe you might gain a little bit more capacity, but you still have a lot of symptoms in one area. So, so I guess what I'm saying is, if you find that you're languishing in exercise, I want to encourage exercise. Don't get me wrong. I think to the degree that you can, everyone should try. And you should try to push yourself beyond what you think you're capable of. I think that's probably good advice for most people everywhere. Okay. But with that said, if the underlying problem is the thing that is preventing you from progressing in your exercise, we'll probably have to solve the underlying problem. Okay. So things like products that help you to be able to measure heart rate or oxygen or changes in HRV are probably useful to the extent that they are helping you push in exercise from the perspective of like, I've got these underlying things taken care of, and now I'm trying to get stronger again. So I think from that perspective, it's useful. It can help you understand a little bit about some of the ways you're recovering, but also keep in mind if there's a pathology underneath it, the numbers in the HRV may not understand the underlying pathology, meaning like they may not, what's what I'm looking for, may not compensate for that. So it's kind of taking like the RMDSS or, some of the different formulations may not, they're kind of more written for normative populations in some ways. So there might be some variance in that, but it can at least let you know, I'm kind of all over the place, but it can at least let you like get some gauge on what that recovery looks like. And it may inform like how hard you work. You may notice that you're not recovering well, which may be a signal. Maybe I need to look at what's going on underneath this to go further. That was a bad answer, but anyway, they can be helpful. I would say that for a lot of people, exercise is great. I want everybody to exercise to the degree they can. If you're finding that you're languishing doing the exercise, you may need to solve for another problem in addition to doing the exercise. That's a better version of that. Okay. That one wasn't great. Okay. Megan, what is the connection between nitric oxide signaling and vascular tone and POTS? Depends on where the vessel is and what you're interested in. So the biggest effects from nitric oxide are going to be in the peripheral portions of the vessel out toward the effector. So in the body, you're going to be out toward like the organs and the muscles. In the brain, you're going to be out toward the brain tissue. And they're used as a local signaling molecule to be able to help us create local vasodilation. So we want the way that we push blood through, really simple, is we want it to increase pressure. We want to create pressure in the more proximal vessels. But as things get out to the actual organ, like to the muscle or to the skin, then once it's pushed out there, then we want it to dilate to go right into that tissue. This is kind of part of the mechanism that we use to go from, I'm like on the conduit out into the muscle. Or another way to think about that would be like, like you're on the train that takes everybody in, and then everybody gets off the train and goes to their individual house. That's kind of like the switch, is where you go from these more central arterial trees into the periphery where they're closer to where they're going to displace the oxygen. So that's what we're thinking about with nitric oxide. So primarily in the peripheral tissues, peripheral portions of the brain, is a signaling molecule to create those little local vasodilations. We don't think about it so much in terms of like the big vessel vasodilations. Those are more autoregulatory, so they're kind of pressure-based signals. Okay, Shannon, how are we doing, team? Cruising along. Lots of questions today. I'm liking it. Feel like I'm talking a lot. Don't love hearing the sound of my own voice, but I hope it's not too bad for you guys. Shannon says, are you seeing people with long COVID related dysautonomia and POTS? No syncope. Well done. Getting back to 100%. I'm told by a long COVID doctor at U of M, it's not permanent, but research makes me question it. I have seen a number of people that end up getting back to normal. I've seen people languish too, but it takes work, I would say. So in my experience, yeah, a lot of people doing better. You'd be surprised how many people are in your boat. So a lot of people doing well. I want to encourage you to keep going on that, because for a lot of people, there's been light at the end of the tunnel. I know it's been a slog. We're a long ways into this thing. But I would say keep hope. But the best way to keep hope, here's the point I'm going to make on this one, is we got to, in order to like feel like there's a compelling future, it's very helpful to have evidence that you can move in that direction. So being able to measure your progress, understand what is the thing that is failing me here, and then can I measure that progress? Because if you can notice, like, hey, I'm seeing the needle move. Maybe it's a really small move, but I can see it move. The fact that you can make it move is the amazing part, right? So can I make it a little better? I'm making it a little better. Cool. Can I just keep that going? And being able to use a measurement can allow you to be able to gain evidence that you're heading in the right direction, even though you may not feel like it in the moment, but it gives you evidence that you're moving. Most people that are recovering, they're coming from a really low base of capacity. Don't have much gas in the tank. So even if you're only adding just a little bit of capacity, you are going to suck it up and like use it without even noticing it. It won't be a big change in your lifestyle, but the ability to like ratchet up just a little bit of more ability, you're going to take it. Ratchet a little more ability, I'm going to take it. So I may not actually subjectively feel like I'm just rolling down the road, but over time, picking that up, you can do more and more and more. So having the ability to measure it and to be able to see the evidence is going to give you confidence. Confidence is going to give you the motivation, keep you going down the road. So that would be my encouragement, is look for those things that you can grab onto, be able to know that you're doing better, even if you're not feeling it yet, to just know that your body is getting stronger along the way. So I'm encouraging you, go get them. I want to hear more good news from Shannon. Bill Thompson, another shout out to Dr. Z from Toronto. Thank you, everyone. Awesome. All right. Megan, did you like take a class before you came in tonight? Where'd you come from? Well done. Oh, great. I was scrolling through and now I lost it. There it is. How does mitochondrial dysfunction or energy production relate to fatigue in POTS? Good. So I think mitochondrial dysfunction, which is going to be a problem with generating energy, is core to all levels of fatigue in a lot of ways. So in POTS, it may be for lots of different reasons, but at the end of it, the ability to run a mitochondria comes down to electron transport chain. You got to have oxygen to run it. This is the core feat. This is like the nuts and bolts of why you need to circulate oxygen. If you don't have it, it's really hard to generate ATP. If If you don't have ATP, it's really hard to have any energy, which means it's hard to do an activity with whatever cell that is. In this case, we're talking about neurons. You may be talking about like mitochondrial dysfunction writ large of like, I have mitochondrial dysfunction. This is my problem. You have to understand a little bit more about why. Every cell has thousands of mitochondria in them. So is it a problem with the way your mitochondria in your, trillions of cells that have thousands of mitochondria in them? Is the way that they're functioning? Is it heteroplasmy? Which is basically their ability to produce energy over time, or the loss of oxidative phosphorylation. But those things are functions of activity and fuel. So how often they're used and how well they're fueled is going to dictate how well a cell works by function of the mitochondria. Woo, got deep on that one. Sorry about that. Okay, just a quick one here. Thank you so much. We love Megan. She is wonderful. She's got a great channel. Actually, those of you that are Instagramists, she's a really good Instagram page that the name escapes me at the moment. If you want to put it in the chat, please do. Yeah. So oh man, I'm way behind on these comments. Okay. Ritvik. What mechanism can explain that talking continuously, say more than a minute or two, triggers lightheadedness or POTS symptoms? Aha. Great question. So one consideration to make for people that feel this sensation is, to what degree are you breathing well? A couple things to consider. Number one, when you speak, are you speaking in like full enunciated breaths so that you're able to like speak, breathe out, take a breath in, speak, breathe out, take a breath in, right? In that process, you're kind of managing your breathing. If I breathe too fast, and like this when I'm talking, I can become hypocapnic and I'll feel lightheaded and icky, right? The other thing that can happen is sometimes like you're worried about your breath, maybe you had a little garlic at lunchtime. People might notice that they kind of like hold it back, or they hold their voice back a little bit. And that holding your voice back, it slows that breathing rate and can also decouple your breathing and make you lightheaded. So those are actually really common in our public speakers. So we've got one that comes to mind is the HR person that noticed this. Also the ability we talked about earlier to be able to create that full rib expansion without becoming lightheaded as well. And sometimes we've also had people, because of the pressure from baroreceptors in their neck, of creating tightness when they speak or turning their head when they speak, can also cause that because it can impair baroreceptor function. So we covered like a lot of different pieces there, but the point is to think about a couple things. Number one, the relationship of your breathing rate, so oxygen, CO2 concentration, then also the positioning of your head, and then also the rate and speed of your breathing, to see if those are things that are kind of like in the ballpark. Those are good places to start to think about. You may notice that by like letting your belly relax, standing tall, speaking loud, and then taking your time and breathing while you speak, you may find that makes it so your symptoms aren't as bad. The last piece is, if you're somebody that does have POTS and you're upright, you may be on a bit of a clock in terms of like how long you can be upright and generating activity to your brain before it starts to get tired. It makes me think of, we do on our tilt test, we have people do some mental math while they're up there, and we want to see, does that bring in a load of cerebral blood flow velocity like it should? But for some people it doesn't. So even just that thinking, using their brain can decrease the perfusion ratios. So that's another thing to consider, is like if you have that type, where the neurovascular coupling is poor, just by up and using language might wear that out and tune you down a little bit too. So a couple different ideas. Maybe it helps. I think it's probably a really useful question for a lot of people because it's a common sentiment among people with POTS. Okay, Ashley, long one. I got to read this one out of the other thing here because it's not going to all fit. I work out, strength training, 3 to 4 days a week. Walk a mile in the morning. Whoa. In the afternoon and in the evening, hoping it helps with circulation. Good for you. But sometimes, more so during my workouts, when I get tachycardic, I will push on, even if heart rate gets up to say 180 or more. My husband thinks I shouldn't be doing this. Is it okay to keep pushing when it gets that high? I do stop if I ever get bad symptoms like the dizzy or I see spots and so on. Ooh, Ashley, love this question, but it's so dang specific. It is going to be hard to answer this one without getting in the realm of giving you advice because you're asking for advice. So I have to give you like the pat answer, even though I don't want to. The pat answer is like anything that starts to like feel dangerous or get into the dangerous territory of your blood pressure, you want to slow down, stop, possibly go to the hospital if it gets too bad, right? That's what you kind of got to say because you don't want something real bad to happen, have stroke, have a heart attack, something like that. Very active, love that. You've kind of got to determine why it's getting up so high. Is that commensurate with the amount of work that you're doing? Does that feel right? Do you feel like you're getting better over time? Do you have a physician that's kind of helping you work through this? It's like, on the ads where it says consult your physician if you want to do XYZ. It's kind of one of those things where it's like, that's the disclaimer is you got to consult your physician. And then kind of do it under someone's guidance, and that someone has to be someone that knows your case. So I'm sympathetic to it. I want to be the one that helps you, but this unfortunately can't be the format that I do that. But I love the yes question. Thanks for doing it. All right. Does having a Chiari malformation roots, hearts, and wings? Does having a Chiari malformation make one more prone to POTS? So this is what we talked about in the beginning of this stream. If you got a Chiari malformation, that's what you got. Can it make you more likely to having tachycardia relative to orthostasis? Can, because when we get in those different postures, we get gravity that's going to affect the ability of that cerebellar tonsil to stay out of the foramen magnum, and it can cause you to be symptomatic, and it may be specific to heart rate, may also be specific to heart rate, blood pressure, and perfusion, but it may have a host of other symptoms that go with it as well. Commonly, you'll see downbeating nystagmus, particularly like what they call corner pocket nystagmus when you look at their eyes. Then you start to see like the beating when they take them over to the sides. That's a simple way to look at it. If you got a VOG, obviously those are really helpful. And then getting the measurement done so you can see what that ectopia looks like. You got to do you like to do it weight bearing so you can see what it looks like when it's under tension. So yeah, definitely good question. Okay. Oh, practitioner, welcome back. I'm on Vyvanse and propranolol for some time. I recently started on fluoxetine. I have the CYP2D6 gene. Do you think the fluoxetine is causing my heart rate to be dangerously low? Never had this issue before. Oh, you guys are getting comfortable now. We're in the range of like we're in the range of questions I can't answer over the internet. But certainly, if you're having questions like that, you should consult the doctor that prescribed it. Talk with them, get their attention. Say, hey, here's what I'm noticing, and see if they can work with you to be able to hit the cocktail right. Wish I could send a super chat. You keep bringing up so many good points. I have lumbar lordosis and ApoE4 and 3 genes. I think one of your subscribers onto something about inflammation and MCAS. Yeah, I look at inflammation and MCAS as secondary features in a lot of cases. Doesn't mean it's secondary in everyone, but we see that it comes like downstream to the effects of having to deal with this for a long period of time. It may not be kind of underlying for some people. So, man, I got a lot to say, but unfortunately, I can't give too many advices, as Arnold Schwarzenegger would say, over this medium. Irene, I'm feeling for you. Dealing with TBI, get your neck fused together. I love that you're reaching out, maybe reaching out in a more formal way to, whether that's to us or not, I don't know that I'm the best person for you, but reaching out to someone that can kind of help you walk through this over time is probably going to be your best bet, even though it requires a little bit of a lift to figure out who that person is that you're going to trust. But yeah, somebody that can kind of help you walk through this thing over time solve these problems forward, is probably going to be a useful person in your life. Austin G. Oh no, Austin G. Skipped your question. Let's see. Let's find you up here. Sorry, my friend. Where are you? Oh, buddy. Ah, this one? Sorry about that. Okay. Thanks for calling my attention to it. Austin G, thanks again. If someone stands with POTS / or fatigued, they get very low HRV numbers, SDNN, etc. Yet when doing breathing or humming seated, these numbers increase dramatically. Why might this be? Okay, low. So if we're looking at these kind of periodic numbers again, so get into the weeds a little bit, the way you measure HRV starts to matter based on the time scale you're using. But let's throw that out the window and just say, like, how could things like breathing and humming improve some of your numbers? Okay. Okay, so I'm missing out on some parts here. It would help me answer this one a little bit better. So breathing and humming can be good ways to start to get coupling within the sensory system. So like as you hum, you vibrate your throat, you're going to get some activation of a couple different brainstem nerves, including the vagus, but also to some degree, you're going to activate your tongue, you're going to activate the hypoglossal nerve, et cetera, right? So you activate these nerves, they go into the brainstem. Those can be super useful if the problem is a brainstem related problem, where amplifying those sensory signals becomes useful. So in cases like that, that can be a really healthy tool. Same thing with breathing. By doing breathing at different paces, if you're interested in that, I did a really good talk with Tim Mann a couple lives ago, had some really good inputs on breathing. Go check that out. He did a great job. But doing different breathing exercises can be helpful because of the way breathing is coupled in the brainstem. Your respiration is actually like the core bass drum metronome of the system. So your respiratory drivers actually drive outputs that affect cardiac outputs and vascular outputs as well. So by creating that synchrony within the breathing, you can normalize those. Again, these are both instances where we're using alterations of sensory inputs to change integration in the brainstem and then change the output. So if we're finding that those things are useful in someone, then it may be worth considering whether or not some of the dysfunction is in not being able to amplify those signals, have them read in the brainstem, and maybe that's part of the territory that we want to try to correct for. So really good question. Specific to that, then we would also maybe consider, if that's true, could we look at other areas that have sensory motor integration in the same nuclei? And then we can corroborate that. So you may choose to look at a couple different, you look at your palate, you can look at corneal reflexes, you can look at some relationships with vestibular reflexes and start to localize within that area and know, hey, maybe the problem is right here, and I'm going to use these mechanisms to stimulate that, make it stronger, rebuild it again. So really good question. Like a budding functional neurologist right there. I love it. Okay, thank you so much. Let me see where I'm at. Wee is dry needling the same as acupuncture? It is a form of acupuncture in the sense that you're using an acupuncture needle, but you're using it largely to stimulate into the soft tissue. Some people will do it in different ways where you kind of accelerate the poking. You're trying to break up trigger point. Some people will do it with the goal to decrease muscle contraction, and some people do it to try to break up scar tissue. Acupuncture, as it's traditionally done, is going to be more related to like chi and the meridians of the system. I don't use the right language because I'm Western and I'm not trained in Eastern medicine, but basically we're using them as stimulation points to be able to normalize function within the different waveforms of the body. So you're kind of placing them, holding them. They may give you an electrical signal through them, but the points that you use are going to be relative to the meridians that they're in, or where you're trying to generate electricity through the system. Okay. Okay. Fat Matt. Severe ME here. I'm thinking you're meaning myalgia, encephalitis. 5, cushions, long COVID. How does one even start to recover? That's the question. It's the right question. I appreciate that. I know that this sucks for you. Okay, so where would I'm going to say if I were in that position, where would I start? I got to start to figure out where I can get a toehold on making myself stronger. So I don't have it. If you're there, energy demand is tough. The ability to use your brain is tough. You got all these lingering things is tough. How do I start being able to stimulate the system at a dose I can tolerate in a specific area that I can tolerate? If you don't have a lot of energy to give, you can't waste it on stimulating everything. You got to go right to the areas where the function is more limited. You're going to have to do it at a dose that you're bringing way down. Some of the things that become problematic when we think about rehab is we expect we should be able to do the things that we would normally do. But if I've got areas of dysfunction in my brain, it's kind of like they have the flu, like they don't have the same output. So whatever they're in charge of, I have to bring that stimulus way down to the level that they can tolerate and then start to bring it up, which may feel like it's at a level that is like I'm doing nothing. But that's where you start, so you have the ability to start to bring it up. It's hard to know which areas to affect in this format. You're going to probably need to find somebody that has a talent for being able to analyze that, measure it, be able to show you where it's at. And if they can show you where it's at, then you can work together and say, okay, these are the things we do to stimulate that area. Let's see if it works. Let's see if we can make the needle move. And you just keep doing that till you run out of problems to solve. I know it's work, but you're here. Just step in the right direction. Anything we can do to help, let us know. Good luck, my friend. Okay. Irene points out it seems hard to know where to start unraveling it. Yeah, that's super true because unfortunately, there's not an easy fix to it. There isn't really a pill. There isn't one exercise you can do. You guys all don't even fit into the same criteria on like what's wrong. So it sucks for sure. And unfortunately, it's hard to figure out on your own. Most people that end up with a neurological problem don't start out as neurologists. So it's like you're just humming along doing your normal life, and then now you're expected to be a practical neurologist and figure this stuff out on your own in a brain that's already struggling. It's a tall ask. Um, it's not lost on me that obviously I'm a practitioner, like I have skin in the game of this, right? This is how I make a living. But also, like whether someone would choose me or not, you're most likely going to need somebody to help you that has a skill set in doing it. Which is tough because there's always costs and there's always trust and there's always all the pieces that have to come with that don't make it easy. I get all those things, but also I would also encourage you to think about the fact that like we all live on a pretty fast time scale, meaning like we're not here that long. So anything that you can do that moves the needle quickly, um, it's worth doing. Life without your health is a lot tougher. And I don't say that from a place of like, buck up. That's not what I'm saying. But what I'm saying is it's really hard to do on your own. And my experience has been that a lot of people end up languishing for longer, trying to figure out on their own. If you can get some help with somebody that you really trust and that you really believe in, that'll be worth it. So I hope you do. Thanks, guys. Okay. Sorry, that's a little somber one, but those are tougher. Okay, Megan. All right, Megan. As you know, most people travel to you. I do know that. Do you have any tips for those that don't travel well to help get through it without feeling like death? Great question. Difficult question in some ways because you're all different. But traveling on an airplane, some of the challenges that you're going to face are like, number one, just like being in position for a while. That's the thing. You're going to change the pressure in the cabin. That can be tough on some people. Just the elevation or the otolithic stimulus can be tough on people. Those ones are harder to deal with. Some things that we commonly recommend, if you know you're sensitive to pressure, they make these earplugs you can buy. You can get them on Amazon, but they're for barometric pressure changes. Some people also use them with weather changes as well. But you put them in and they've got this like little hole in them. Pretty inconspicuous, but they got a little hole in them, but it is like a damper that slows down the pressure change. So if you're sensitive to those pressure changes, you can wear them. At least buffer that down so it's not so dramatic. That could be one. Number two might be if you notice that you're someone that has like trouble with your eyes and like they kind of cross on you, or one starts to elevate like that, or you look at if you notice that you watch that movie screen in front of you for a while and then you look up and like the cabin's blurry, those types of people will probably benefit from maybe like not looking at the screen that's 12 inches away from your face for 4 hours, but maybe looking further off into the cabin, listening to something, not having your eyes be close together. That can be helpful. Those are just some simple things. Other things to think about might be when you arrive at your gate, being able to sit down or lay down for a minute and just kind of recalibrate, find the ground again. When you get to wherever you're going, kind of calibrating, getting on the ground, go for a walk if you can. I know that's not everybody in this boat, but just kind of some simple things that you can do. Go out and look outside, make sure your eyes can like reset in space again. Those are just simple things that people can do. Make sure you're super hydrated before you get on the plane, and try not to do things that are diuretic on the plane. So like drinking coffee or stimulants and things like that. All those things are just kind of simple things you can start with. As far as dealing with time changes, all you can read about that anywhere online, where you kind of talk about getting on the right eating schedule, getting to bed on time, using some sleep hygiene to help you kind of get back on track quickly. Those are the simple ones I have. All right, let's keep going. Ashley, thanks for coming. She's got to go. Maybe you can catch the rest of it later. Thanks for being here. Megan, okay, her page, the Good Brain page. Go visit it. It's fun. They did a really good workup on her. She's wonderful. Go check it out. Okay, Urban Hippie Mom, diagnosed with autonomic disorder, POTS, hereditary, hypermobile Ehlers-Danlos symptoms, Raynaud's, and blood work shows low C3 but no other autoimmune markers. Trying to understand the potential link or significance to underlying cause. I don't know that low C3 does relate to the cause or not. It may. You consider if you've had environmental impacts in your home, that may be a thing. If you go on vacation or you go somewhere dry, you feel a little bit better, take a little trip to Arizona. Does that feel a little better? That might help. Also considering, man, I'd love to just do a workup on this. I don't know for sure. There's not enough details to really know what would be the underlying cause, although I'm sure somebody that's trained to do it could probably figure it out. So I'm wishing you the best. I hope you get some help. I don't know where you are. Let us know where you are. Maybe we know somebody near you and we could get you some help. But thank you for being here. Okay. Okay, we've got Ritvik. Thank you for a great answer. Is there a specific posture apart from lying down flat that you can recommend for a POTS patient, which can make it easier for them to do seated office work? Good question. So while you are seated, I'll give you just a sense of some of the advice we gave today, and we give it reasonable amount. So if we're trying to account for postural related things without knowing what's going on, one thing you might consider is just the nature of your chair. And I'm trying to cover like a lot of bases because there could be so many things, and I don't have one advice that can get to all of them. But one thing we do recommend is sitting cross-legged, not like crossing your knees, but like sitting like you're sitting around the campfire on the ground. Crisscross applesauce, I think, is the correct way to describe it now. But sitting like that, even in your chair, allows you to shift your pelvis so you can be more upright. If we're having any kind of vascular compromise in the thorax or in the body, that may help open that up in a way that becomes useful. If we're finding that you're still hypoperfusing, being upright in general is probably going to be tough. If it's related to posture of your body and neck, obviously being like this allows you to sit up and hold a posture. Maybe that helps you with improvement. So you're just trying to like normalize as much as you can. If it truly comes down to just like the orthostatic gradient, it's going to be really hard anytime your heart's over your chest without knowing how to solve it specifically. But that's kind of where you could start from. You could also consider, I saw this guy that made he took like a regular desk chair that tilts back. It's got a little leg lift thing on it, and then um, he mounted a screen and then had a little like electronic keyboard. So he was actually kind of laying back with the screen up like that, working like that. So that could be an option too if you're just looking for a full hack mode. Well, good luck. Corey, would breathing issues be more of a symptom, or could episodic breathing changes be more causative to permanent long-standing body compensations in O2 CO2 relationship? Okay. Yeah, so this is like a chicken or egg sort of question. And it can go both ways, honestly. So some people may know that um, like if you've got a problem that kind of the origin story is in the brainstem, you may find these episodic ranges where your body doesn't correlate it. You kind of get like an ataxic breathing where same way someone might like have a tremor or like, like not have accuracy with a limb, you may kind of notice the same thing with your breathing where there are time frames where, under different stresses that it doesn't act right. But also you can have the opposite where you're looking at here, like positions of the body can also be the things that can cause the changes in the breathing. So it can kind of go in both directions. We've talked about this a little bit, but I think it's a good question. Um, so it can go both ways. You kind of got to figure out. A lot of times you just try to fix it from both sides. So if you're going to work on it, what we will often do is just say, let's look at it from both ends on the anything that could cause the episodic breathing, the brainstem component, and then also postural, etc., things that also influence breathing. But always thanks for being here. Really appreciate you. Practitioner, thanks from Houston with a heart. Love that. Irene, how do I search for someone with your hands-on knowledge in my area? Anyone like me in New Jersey? You can look at dacnb.org. I've also got a good friend, Aldo Scopoletti, that's in New Jersey. New Jersey's a big place, so I don't know how close he is, but he's a friend that comes to mind. And you could look up some people, start there. We're always available. Trip to Michigan, but it may be useful for you to kind of start near you. Love it. Hey, Bella Thomas. Found a short article suggesting creatine. My daughter and I have been on it for a week and both feel a boost of energy and more able to do life. Any ideas why it may be working? Is it purely the cellular hydration? So creatine's been shown to be useful, just like a general. It's kind of fallen lately into the nootropic category because it becomes basically like a derivative food source in the brain. So it kind of helps boost a little energy because it makes it easier to come across the fuel. So for a lot of people, there is some concussion. Ooh, breathe. There's some concussion literature that suggests that creatine can be useful. It's a useful product. It's got a low risk. Can be really great. We recommend it all the time. Yeah, good choice. I'm glad it's working. I hope you're using like a really good version, really clean one. Everybody's happy about it. Yeah, awesome. I'm glad that that's working for you. Mary, just wanted to say, hey, hope you're doing well. If you're watching, this is the guy to see goes, endorsement from our lovely Mary. Awesome. Thanks for being here. I always like seeing your name come up. Thank you. Our hippie mama said, can low vagal tone implicate heart arrhythmias? For example, ECG shows Brugada patterns. It can. And that can actually be one of the causes that we see with a number of different arrhythmias, particularly like in the AFib category or the PACs. So yeah, absolutely. If those are popping up, maybe let's make sure that everything's good in the nodes and in the bundle branches and everything as well. Cool. So make sure you get like the good heart workout. Fat Matt talking to Irene. Look for functional neurologists in your area. They have to have somebody in New Jersey. Just make sure they're good. Cover chronic illness pain. Yeah. Listen, great advice, Fat Matt. I love that. Thanks for contributing. Thank you. Heartfelt. And also keep in mind, like, there are people that have like just different skill sets. So some people, like you go to the dentist, some dentists are great at some things, some dentists are great at other things. We're all humans, we're all good at the thing we're good at, right? So with that said, if you're kind of like new to the search, you want to look for somebody that's a good fit for you. That means like you feel like they know your specific type of case really well. Okay. So you may find that some people are like really good at sports. Some people are really good at autonomics, whatever. Make sure you feel good about that person. Make sure that you're comfortable with them, that that it feels like a good fit. And if not, find another one. Like there are people available, but don't give up on it, is my point. So find somebody that fits, find somebody like not everybody's created equal, but if you don't jive with the very first person, find another one. Keep going, keep searching. Great advice, Fat Matt. Thank you very much. Also, I want to know why you're called Fat Matt, but maybe you don't have to do that. Okay. Do you have live talks most Thursdays at this time? We've been trying to do them every Thursday at this time. We'll do different things. Sometimes it's more Q&A like tonight. Sometimes we'll have somebody that's a guest to come teach us about something. Sometimes we'll talk about a case like we did last week. They're all in, if you go on YouTube, they're all in like the live section of our thing. You can go take a look at them and you're welcome. Please come join us anytime. And Shannon, I appreciate your reply regarding long COVID. I'm also dealing with MCAS and SIBO. Functional med appointment today. Talked to Claire recently, setting up an evaluation soon. Shannon, I really hope we get the chance to help you out, if it's the right fit, obviously. But thanks so much for being candid for everybody here. And remember that like you guys helping out and progressing along may be the thing that sparks a thought in somebody else's mind and gets them like to a new idea that may be really useful for them. So thanks for doing this. Matt, no, thank you, sir. I really appreciate it. Eileen, how can I start talking to your office if I doubt if it's possible to travel? Okay, anything? Yeah, I appreciate that so much. If you want to consider that, you can look us up at kaiserclinic.com. Talk to our team there, and they can start working through whether or not we think there's a window to help you out. That's a great place to start. They'll shoot you straight on that. Okay. Lexi. Coat hanger pain so bad I can't exercise and barely use my upper body without pain and headaches that follow. Any suggestions? Okay, there's a lot more I want to know here. So much. Okay. But we got to determine why you're having it. And if it's from something that's neurogenic, something that's like from a nerve, something that's sclerotogenous, something that's hypoxic to the muscle or to your brain, something that is coming from like joint tissue. When I say sclerotogenous, I mean like joints, discs, ligaments, tendons, things like that. Are we in a rough posture? Are we moving in a way that like we're creating some friction in that system? So many things. I really want to help with this. Maybe first things to consider for someone that's dealing with coat hanger pain, trying to exercise, is just start off with what is the just general sensitivity to the area just on the skin? Do we have any changes in the skin? Is there a posture here that's going to be problematic? You know, are we getting into these where we're super ear in front of our shoulders? Are we having problems with perfusion where I'm getting lightheaded at the same time while I'm doing it? Dizziness? What's going on? And you're going to have to work backwards from there. I want to answer this question. There are so many variables here. It's hard to pin it down. I love that you're asking for suggestions, but those would be the first to start. Like, am I able to just like hold a neutral posture? Does that affect the coat hanger pain? Am I getting tachycardia? Am I getting lightheaded? How are these things all playing together? Okay. Thanks to Megan for the page. Super good page. I think you guys will love it. No harm in a follow. Roots. Sitting crisscross applesauce right now. Love it. And this is a common thing that I explain for people that are sitting on the couch. I feel like Western couches are not optimal for people in our boat because it like fully gives you a slouch posture or like a lay down and crank your neck over posture and things that generally don't make people feel good. So thing to consider, try going crisscross applesauce, see if it helps, see if you notice like you sleep a little better, you don't wake up as weird, or you can like watch TV a little longer or something like that. Cool. Thank you. Dr. Ginia throwing out contact info in the chat if you need it. Yep, DACNB. DACNB. Maybe I can throw that in there. Oh no, shoot. Claire always gets after me for this. It's acnb.org. Hold on. It gave me a little autocorrect. acnb. There we go. No autocorrect. So my credentials are DACNB, so I messed that up. All right. Woo-wee. Way to go, team. Okay. Is it safe long term? I think this is going back to the creatine. Nothing is shown so far that it's not safe long term. And a lot of people will cycle it. So they'll do it for a period of time, come off, do it for a period of time, come off, as a way to kind of not regulate to it. So, but nothing seems to say that it's had any harmful effects so far. I'm not the expert in that, but I do try to keep up with some of the reading on that. I haven't seen anything yet. All right. Wait, how can we advocate for treatments you use, such as HPOT, red light therapy, being prescribed and covered by insurance? That's a great question. You're going to have to get into lobbying, probably, unfortunately. You can speak, every insurance is different. It's hard to know. You can speak with your insurance provider and try to talk to them about the utility of that. But the general incentive of that relationship is to not pay for your stuff, unfortunately. So because of that, it's a harder question. So, but you as the person that pays the premium, you have the best chance of being able to talk to somebody, seeing what the availability is. It's just hard, and they're going to try to run you around a little bit. So be ready for a wrestling match. Okay. What kind of interventions are used for chronic hypocapnia? I have to imagine many times hypocapnia could create more hyperventilation due to body sensing low oxygen. Buteyko, perhaps? Yeah, Buteyko breathing is actually very interesting. I like it. Do you have one of the little breathers? Those things are actually pretty cool. They kind of pace your breathing out. But the question that I run into a lot is that what's causing the hypocapnia? So you want to see what is the breathing rate? Hypocapnia, for those of you following along, Corey's ahead of the game, so he's got it. This is an advanced question, but hypocapnia is decreased CO2 levels that are in your bloodstream, that are dissolved in your blood. The CO2 in your blood is kind of one of the things that your body detects, or your arteries detect, to be able to control how dilated or constricted the artery is. So if we start to get low levels of CO2, what can happen is those vessels will actually start to constrict locally, which isn't great if we're thinking about blood flow. So this is where you see people that hyperventilate, like in a panic attack, turns into panic. And then you also notice you get numb and tingly around your face, or your fingers might start to curl up like this, or your toes, right? So these happen with hyperventilation. And hyperventilation can be two things. It can be hyperpnea, which is when you do the big breath where you, right? So you're breathing too fast, but you end up blowing out too much carbon dioxide, and it makes it so you get lightheaded because of vasoconstriction. And the other way is, so it's hyperpnea, and then there's tachypnea, which is you're breathing too fast and shallow. So what Corey's suggesting here is if the hypocapnia is relative to hyperventilation in one of those ways, one of the things that we can do is we actually notice that we start to shift the concentration of oxygen. One of the exercises people do is Buteyko breathing. And there are some different patterns that you can do that with breath holds, and then also being able to use the little breather. And those are interesting, promising, worth a shot for a lot of people. The secondary component then, as we talked about, is is the hypocapnia actually just relative to sensor error, independent of breathing? So we actually end up with a lower resting state, in which case We want to think of it like a muscle. I'm putting more resistance against it. I want to be exposed to higher levels of CO2 and actually make the body better at detecting and tolerating those lower levels. This is kind of where some of the work comes from, where they're doing, taping across the mouth and exercising, just breathing through your nose, where you're trying to build up more CO2 in the system so you can become tolerant to it. And for what it's worth, those things can be interesting. There's a great book on the Buteyko method if you're interested in that as well. But easy things to try. You'll know if you don't like it because you'll get loopy and pass outy. Just decrease the dose. Go a little bit easier on yourself. Don't try to go ham like athlete level to start with. Start out really basic and simple. Cool. Irene, just throwing out a thank you to Fat Matt. First choice travel to Michigan. Thank you very much. I appreciate it. But again, I don't want this to be a sales pitch for me. I want to just be useful to you guys. We just try to get you wherever you can get better. Let's get the clock moving on, getting you feel better. Okay. Melanie, hello. Hi from Canada. Downward eye drift is gone as of last week. Doing great things with my home exercise program. I love it. That is amazing. You are a walking miracle. I really love and appreciate you guys. Super high from Chelsea, where we had snow today, to match yours. I don't know, you guys, how many feet you guys got up there? Anyway, love it. Thanks so much. So glad to hear from you. Oh, we got another one from Melanie. I can't thank you and everyone at the clinic enough for my progress. Thanks so much for saying that. We do appreciate it. I really appreciate you. Thank you. And then Bella says, thanks for your advice. It's been life-changing. Ruth, me too. All the time. My daughter and I were able to work out a way to come and see you from the east coast of Australia. How long would you suggest staying for? Oh man, that's a great question. What I would suggest, and this is for you and for anybody else. So the way we usually do onboarding is we want to know about you first. We want to know if we think we can help. That's the first step. So we'll a lot of times ask for some history, ask for a lot of background. We do kind of a long phone call with you just to see if it's even worth it first. Because we don't want to waste your time. We don't want to waste your resources. We want to try to get you to the best place. Okay, so that's first. So we may say, like, maybe go there first, check that out, let us know if you need help, or this isn't a case for us, let's send you here instead. Either way, we'll try to direct you toward whatever the next best step is. But that's what I think about. So knowing like how long to spend, I don't know without knowing more about it. And we're just trying to make sure we do the right thing by you guys. Okay, so if it works out, we'd love to see you. If not, we'd love to get you some help. Awesome. Thank you so much. Fat Matt, can occipital neuralgia cause you to be bedridden on its own? I think I got a mixture of that and CCI going along with the other problems as well. I mean, it depends how bad the head pain is. Occipital neuralgia, classically, suboccipital neuralgia is where we get kind of compression or inflammation on the nerves that are exiting the back of the neck. It tends to refer, like you push in there, it tends to refer like right behind your eye on that side. It's usually unilateral, and they can be pretty rowdy. They can be pretty rowdy, but a lot of people like can get by with them to some degree, usually not fully bedridden. I'd be curious to know if that's all that's going on or if we've got any pressure changes or anything like that. So just something to consider, especially if you do have CCI. You want to get, most of the time people will elect to get some testing done to make sure their intracranial pressure is okay too. Okay. Gwen, hello from New Zealand. All right. Oh, best accent. Ooh, I can't say best because I love my Aussies, to be fair. Awesome accent as well. But I love a good Arner. I pass out a lot with POTS. The doctors say I have to just get used to it. Any advice? A couple things here. Thank you for joining us. Thanks for being here. This is helpful for us and everybody else. If you're passing out, we've got to take a strong look at if that is POTS or if we've got something else underneath it, because a lot of times if we're just looking at POTS, the elevation in the heart rate is usually enough to sustain the blood pressure. The thing that makes it POTS is that the blood pressure doesn't change. And if the blood pressure is not changing, we want to see if we're creating a real problem with hypoperfusion, cerebral hypoperfusion. Or we look at if the blood pressure is dropping to understand if that's why you're passing out. So POTS specifically, maybe, maybe not. So we want to, this is a case where you want to really start talking to someone about, like, let's look at my perfusion in my brain and see if I'm getting enough blood flow in my brain. I'm not giving medical advice, but that's maybe a good place to start, is why am I passing out? Am I just starting off when I'm on a tilt table? Do I pass out? Am I losing perfusion in my brain at the same time? Is a really good place to start. Let's try that. Okay, let's go do that, please. Not advice. I'm going to have to watch this talk. These ones will take notes. Thanks, Irene. Corey, thanks. Makes 10 cents. Haven't seen the breathers. Very interesting. Yeah, go check them out. There was a moment in time where we were trying to figure out if we could get a patent on them because they were coming out of Russia. Long story, but they're actually a cool tool. You might really like it. You can also look at doing just that, like exercise like we've done, talk about, and then try doing it just breathing through your nose. You'll notice that you want to change your breathing pattern so much, but that can help you, down regulate it, push it down. You won't be able to do as much, but it's an interesting thing to check out if you're interested in exercising. Okay. Janine, I'm going to say Janine. If I got it wrong, I'm sorry. I've got POTS and Stickler syndrome. I think I might have MCAS too. I've been tested for MCAS twice and my tryptase levels come back normal. Is it possible to have MCAS and normal tryptase? I think that's a tough question because typically that's kind of the diagnostic criteria. You may start to consider, like, am I having these histamine type reactions as a function of like excess activation within that system? So like the same way people will tend to notice they get things that feel like adrenaline surges, or they might notice they're sweaty, like hot sweaty, may notice that their armpits are a little extra stinky, pupils might be big. When we think about those things, these are all separate features of sympathetic nerves, but if they're all happening together at once, then there's something from a higher order, something from the brain that may be causing them to all activate at one time if we're not specific to something that our body is reacting to. So that might be a good place to start for you. For someone like you in that scenario. Corey, I've considered trying to hostage tape for sleep as well. It looks intimidating. It looks intimidating to me too. These ones, I don't like those as much, but the ones that just kind of reminds you to keep your mouth shut here feel like an easier barrier of entry. And you can still like sneak one out the side if your nose gets clogged or something. So those feel less aggressive to me. You'll have to let me know what you decide to do. All right, team. Well, we've been going for 2 hours plus. I had a wonderful time. Thank you so much for your time and attention and just like heartfelt, great questions. I really appreciate it. It builds the community. It's like the only reason I get to talk is because you guys have good questions to ask. So I appreciate that very much. And we'll look forward to doing it again next week. Save up your questions. We'll find something cool to talk about. If you've got some suggestions, let me know. Anyway, have a great night. We'll talk to you soon.